This is a short video describing the pathophysiology of ischemic heart disease. The key to understanding the development of ischemia is appreciating that it occurs as a result of a disturbance in the normal balance between the supply and demand of oxygen to the myocardium. When supply of oxygen is reduced then, myocardial hypoxia may ensue, particularly if compounded by situations that increase demand. This diagram looks at the issue in a bit more detail. As we know, the left ventricle of the heart pumps blood via the aorta to the rest of the body, and right at the beginning of that pathway, the aorta gives rise to the coronary arteries, so supplying blood to the myocardium. Now, imagine we were able to fix devices that monitored the stresses of the body, the oxygen demands of the myocardium, and the degree of blood flow reaching the myocardium through the coronary arteries. When the body is under increased stress then, classically due to exercise, the heart promptly reacts to this by increasing cardiac output, mainly through an increase in the heart rate. This process increases the myocardial oxygen demand, and to allow for this, there is a compensatory increase in the coronary blood flow to the myocardium, and this volume is known as the coronary flow reserve. Problems can arise when there is a restriction of blood flow through the coronary arteries. This is commonly due to atherosclerosis, in which deposits of fatty material known as plaque build up in the large and medium-sized coronary arteries, and so limit blood flow to the myocardium. When the restriction is sufficient to occlude the luminal diameter by more than 70%, stable angina, also known as exertional angina, arises. In other words, now when there is increased stress on the body, the myocardial oxygen demand cannot be supported through the coronary blood supply. The smaller arteries distal to the stenosis are maximally dilated, and the coronary flow reserve is near zero, and thus ischemia ensues. It is this ischemia that produces angina, which is termed stable as its production is dependent on the myocardial oxygen demand. This isn't the whole story of how ischemia can arise, however, as it can develop more acutely and severely. As a plaque becomes more advanced, the arterial wall thickens and hardens, whilst smooth muscle cells multiply and move to the surface of the plaque, contributing to the formation of a fibrous cap. Over time, this cap may erode and break open, releasing plaque into the bloodstream. The plaque can flow downstream and undergo thrombosis, completely ceasing the coronary blood flow through the artery due to total occlusion of the lumen. The acute event produces ischemia irrespective of whether the myocardial oxygen demand is otherwise low, and produces an acute coronary syndrome, which will be discussed in more detail shortly in this chapter. It is important to be aware that the distinction between these two processes is not so clear-cut as this in reality. Indeed, in some cases, ACS may arise simply due to a gradual worsening of the stenosis that normally gives rise to stable angina, though the ACS is less likely to be as acute as that occurring due to thrombosis.